Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 123 of my podcast for July 14th, 2011. Today's episode is produced in partnership with the Healthcare Value Network, and you can learn more about them by going to www.healthcarevalueleaders.org. And today's episode is a discussion with two leaders from Group Health Cooperative, a consumer-governed nonprofit healthcare system based in Seattle, Washington. And my guests are Dr. Claire Trascott, the Primary Care Medical Director, and Alicia Eng, the Vice President of Primary Care. And we'll be talking about their use of lean principles in the design and ongoing management of their medical home approach to primary care and wellness. And if you want to read articles that describe the benefits to the patients and caregivers beyond what they'll talk about in this episode, you can visit the blog post for this episode at www.leanblog.org/123. And if you want to hear an earlier interview from back in 2007 with some other leaders from Group Health, you can go to leanblog.org/23. As always, thanks for listening. Alicia and Claire, thanks for taking time to talk about your work here on the podcast today.
You're welcome. Great.
Alicia, we're going to start with you. If you can introduce yourself to the listeners and talk about some of your background, please.
Sure. My name is Alicia Eng. I've been with Group Health for the past 14 years. I'm currently in the role of Interim Vice President for Primary Care Services, and have previously been in administration and clinic operations manager role within our primary care system. More recently was the clinic manager of our medical home pilot site in the Factoria, Bellevue, Washington. And I'm now excited to be working on behalf of primary care overall.
Okay, thanks, Alicia. And Claire, if you could tell us a little bit about your background and also give an introduction to Group Health Cooperative.
Sure. I'm a family medicine physician and have been a practicing physician for a long time, over 25 years, but currently hold the position of Medical Director of Primary Care at Group Health Cooperative. Group Health is a large integrated system of healthcare. We have both a delivery system and a financing system or insurance plan. We serve about 600,000 people in the Pacific Northwest. We have 26 primary care clinics spread across the state of Washington, with one small one in northern Idaho as well. Primary care also encompasses behavioral health and a few other parts of the organization, but I think today we'll be mostly focused on primary care in the clinics.
Okay, thanks, Claire. And we're talking about the patient-centered medical home and how that works and the overlap with Lean. But Claire, can you give some of the basics? A lot of listeners might not be familiar with the term or the concept. Can you describe kind of the basics and the highlights of what is the patient-centered medical home?
I think when you talk to people all over the country, you could get as many stories as the people you talk to. So it's a somewhat loose term. It isn't greatly defined, I would say. We do have some guidelines, though, and we have set up some national guidelines. I think one of the better ways to explain it at this time would be just our story of what the medical home is. When we attempted to provide better and better service to our patients in a setting of also implementing an electronic medical record, we had certainly a significant workload problem and a quality problem in primary care in our clinics. And we decided we needed to redesign the workflow in primary care. And there were a couple of important principles. One is we did bring in Lean as one of the ways we approached it, and that was the first time our organization had used Lean. And secondly, we co-created it with our research institute, and ours was created on a vision of relationship-based care. It stresses the interpersonal relationship between the physician, their team, and the patient, and continuous healing relationships. The patient-centeredness, at least in our design, came from the fact that a patient needs to be much more engaged in the direction of their medical care. That a treatment plan for a patient is partly created by them with very individual targets them understanding it and feeling like they own it. It isn't just a prescription handed to them by a doctor. So there's a different way that the patient is engaged in this care. At the same time, we changed the way we flowed work in our clinics so that we could more effectively have interpersonal time with patients, form stronger relationships, and use IT and other systems to be much more effective and efficient with this work.
And the term, just even the portion medical home, doesn't refer at all to anything taking place in the home, but it's that the patient chooses a primary care relationship to be the home for their health maintenance or health care. Is that fair to say?
That is fair to say. It began in the 60s in pediatrics and as a pediatric medical home, and it was thinking of your primary care physician as the person that coordinates your care, that you come home to, and everything else, it's like the hub of a wheel, and the rest of the healthcare system is coordinated from that site.
I think another way to think of it, rather than taking place in the home, is the patient's home base. As Claire says, it doesn't necessarily mean that primary care clinic and practitioner does everything for that patient, but like she said, it's the coordinator, and they know all the things that are going on with that patient.
And so that collaboration between patient and that primary provider plays the role of coordinator. And would you say that in the medical home, the primary care team has a better picture of that patient's overall health? Or let's say if a patient's been referred to specialists or other providers, that they can you tell me how does that better coordination or visibility to care take place?
One of the more important things is that with the EMR and with the technology we have, we actually can see what our patient needs actually before they know they need it. So we know who they are, what their age is, what their past history is, and with our electronic medical record, we can understand whether they need a certain type of exam or a certain type of test. We also can see who they're touching and where and when and why, and understand what's going on with them. And so we have an ability to be much more proactive in how we do healthcare and pull people in. Prior to this, healthcare was done by you happen to show up at your doctor's office and they address what's going on today, and maybe they see your long-term needs and maybe not. This is a way we pull even low utilizers into healthcare and see what they need before it even occurs to them that they need it.
And then from that aspect of being proactive, undoubtedly there are patient benefits in terms of their health, but then with the structure of group health being both insurer and care provider, I would assume, or maybe you can tell us what the benefits have been to that integrated system that you have of being more proactive and, as you said, calling in patients to help maintain their care. Can you share some examples or data about that?
Well, I can say that, so also group health is a many large multi-specialty groups. So we consider ourselves a primary care-based healthcare system, but we actually have a much larger and much more expensive multi-specialty group. So how a patient navigates through that specialty group and in and out of hospitals and other sites is coordinated more easily through our electronic medical record. So again, we can see what's happening in all those locations.
Mm-hmm. But when you talk about the idea of bringing in so-called underutilizers of care, there's a lot of discussion when people talk about healthcare costs of the other side of the equation, overutilization of care, and in maybe in a less integrated type approach, bringing more people in for more care might add costs. But is it true in your system that being more proactive with patients is actually reducing costs? I believe I've seen some data that talks about reducing hospital admissions and reducing emergency room visits.
That's absolutely right.
Alicia, would you like to jump in?
That's absolutely right, Mark. And with our model of a health plan and delivery system, there's not incentives for our physician staff to do treatments and procedures that are medically unnecessary or not evidence-based, and we have actually incentives to take care of our groups of patients in a more preventive, holistic wellness way. And from the original pilot at Factoria and subsequent spread, the decrease in ambulatory care sensitive hospitalization and inpatient days and ED urgent care costs have paid more than cover the additional investment in primary care.
Mm-hmm. And I mean, it sounds like it's a great system with benefits all around. I know when I've had the chance to come visit group health and see the clinics and talk about the process and proactive management of care, my own reaction was to wish that I had a similar sort of setup here in Texas, because like a lot of patients, I have the kind of traditional fragmented, reactive healthcare. But Alicia, turning the conversation a little bit toward lean, can you share for the listeners how lean concepts or the many years of lean learning and implementation at group health contributed to the design and the ongoing work of patient-centered medical home?
So the original pilot we did at Factoria was at a time when group health hadn't formally adopted a systematic lean strategy. So what was piloted there and studied by our research institute was a multitude of strategies that we implemented in the medical home. And when that was successful, we needed to figure out a way to codify that or break that down. And so our initial step around applying lean to this work was around doing a value stream mapping event. So looking at the success at that one clinic in Factoria and defining and understanding what were those elements that made this work successful. And so our first application of lean in the medical home was to do that value stream event and figure out what that was, and then needing to figure out the strategy to spread that work. And so the way we did that was to identify those 7 or 8 elements that needed that we should spread, and do a rapid process improvement workshop on each one of those elements, where we bring frontline teams together, multidisciplinary group, for a week to design the standard work for each of those elements. And then with 3 clinics, tested that standard work, improved on it, further defined it, and that's what subsequently got rolled out every 10 weeks, each element being rolled out every 10 weeks to every clinic across our 26 medical centers.
And in that value stream event, was that a value stream of high-level patient flow through the overall care process, or what were the boundaries, kind of beginning and end point of that value stream?
It was a value stream map around the various strategies, whether it was around how we take care of patients in the clinic, how we communicate and meet their needs virtually, how we prepare for the visit, manage acute care needs and chronic disease needs. So everything from staffing to operational process flows.
So I want to ask, follow up, when you talk about standard work, and I'd be curious to get both of your perspectives on this. For people outside of healthcare who are familiar with standard work, they might think, and in fact, this is the same thing that gets said sometimes by very experienced clinicians. On the one hand, you talk about very personalized, individualized patient care and individualized patient health. But then, you're talking about standard work. Can you talk about how standard work fits into that context of having standard processes and using that to set up perhaps the flexibility in patient care?
Yeah, I can speak to that, Mark. As you may know, anytime you talk about lean in healthcare, physicians start to talk about the fact that they will never do standard work, and that we are the factory, and there are many, and we are actually quite concerned about implementing lean in a healthcare setting. What's been surprising to me is that when you do it well, it actually fits very well into healthcare. Physicians are accustomed to doing clinical care in standard ways and adjusting to standards of care. So standardizing work is inherent in the way physicians are trained. and in using data and data systems to see how we're doing, to set targets, to make those visible, it actually fits very well into clinical practice. So that was surprising to me as we did this work. Before we used Lean, we had tried to do some improvements in primary care between different clinics, and we had never been able to get one clinic to adopt what another clinic did on a consistent basis. Lean gave us the ability to actually define standard work, to know if it's being done or not, to make targets visible in the clinic, and actually spread those in a defined way to every single one of our clinics. The management discipline in Lean allowed us to know that or gave us the ability to see it, to make sure it was being implemented appropriately, and today it really helps us sustain that standardization. And I would also say the fact that we do continuous improvement of our standard work and we have input from the entire workforce helps with the credibility with the workforce, is that if they do not think it's the right standard work, they will have some power in changing it for the entire system.
Well, sure.
That's exactly right, Claire. What Claire described was the main elements of our daily management system: the standard work, manager standard work, and the visual system.
And so then one other question that comes to mind is, and I think you touched on the classic Lean cultural component of continuous improvement and staff engagement through the rapid improvement workshops and through ongoing continuous improvement. That just to clarify for the listeners, this certainly sounds like this wasn't a top-down mandate that was being forced on people.
Well, Claire, actually, can you talk about that?
I would think it did. For some people, it did feel that way. Absolutely. I think what we are concentrating now is called frontline improvement, where really it's very much engaging the front lines. But our initial step did feel more top-down. And I would say when you put in an electronic medical record and an electronic scheduling system, there is a loss of autonomy in a big system of healthcare that doctors feel and nurses feel. But it also gives you the power of working as a system rather than an individual. So there's plus and minus of it. We tried to get around some of this by having frontline representation from multiple places in the state with every component of frontline work, and to have champions in different parts of the state on every component. So we worked on this continuously to make sure the voice of our workforce was involved in the work. But for people who had to start to do things a different way than they did it before because we said they had to do it, I'm sure there was a certain amount of top-down feel to this.
It sounds like what you said during those first cycles, there was this idea of spreading the standard work and improving it, that there was some iteration, at least through iterative learning through those first cycles before that process was rolled out prior to then the continuous improvement.
Correct. And we have been, since we rolled it out, we have taken each component and done statewide PDCAs on each of those with input from the entire workforce. So we've changed our standard work. We're continuously changing it on a statewide basis.
And then just one other follow-up question. Claire, when you had mentioned targets, performance measures, making those targets clear, can you summarize what some of those performance measures are from a patient standpoint and from a group health perspective?
We have many, but I'll tell you two of them. One is our clinicians have to chart care plans that are collaboratively designed with the patient, are visible in our electronic record, and handed to patients in a paper copy as well. So all of our physicians need to chart a distinct way for patients with certain chronic diseases. And that we actually look at how many patients in a certain group have a care plan. We make this visible to the physicians, and we require a certain percentage have them at any given day. So that's a type of standard work that really gets into the clinical content and how our physicians do our work. I wanted to also say one other thing about sustainability of standard work and visual systems. We have a call management system where calls coming into the clinic can go directly to the nurse or the physician and have no secretary in between. And so for this to work, there are times during the day when our physician would be the first person on the call. We actually measure this every day. Who took calls, how many minutes were you available? And some doctors love it, some don't. The only way to really sustain this is keep this teamwork engagement visible and speak to it almost on a daily basis.
And Alicia, as we start to wrap up here, do you have any thoughts you can share about some of the performance measures that you've seen impacted through these initiatives?
Yes. So each one of these initiatives, as they were designed, came out with in-process measures as well as outcome measures. So there are things that are tracked and in view at the team level, at the frontline level, around how the process is going for each one of the elements. And it's how they know on a daily or weekly basis how the process is working in their clinics. And they actively huddle in the teams and look at this data so they can know at any given time how they're doing. And the idea around the in-process measures then is that if the processes are in place and consistent and capable, the outcome measures will come. So the outcome measures are things around our clinical quality, access, and our growth or our success in managing patient populations.
Okay, thanks, Alicia. Claire, do you have any final thoughts or advice that you would give to other organizations that are looking at doing this kind of work or doing this work, or any key lessons learned from your introduction to lean principles from your standpoint as a physician leader?
First of all, I would say don't be afraid of it. It actually works very well in healthcare. But I think our biggest learning, as Alicia said, we were learning lean as we were building this and spreading it. And there was a significant difference when we went from using lean as a set of tools and went into the arena of a management system. That's when it really became a much more vibrant change. The fact that we are disciplined, that every Thursday all of us are in the clinics or at the points of care and talking to frontline staff, every level of leadership, that being in the Gemba, that is what has kept it alive, is sustaining it, and really, I think, the most powerful component of what we did.
Thanks, and Alicia, I guess, likewise, any, a key lesson learned to reflect upon, or advice for other leaders that might be listening?
I would just echo what Claire's saying, and it's really around sustaining that and being having the discipline to keep that intact. Because once you stop checking something and stop looking or making it visible, we start to erode.
Well, and it sounds like with that understanding and with the move toward lean management system and staff engagement, that rather than erosion, it sounds like it'll be a thriving organization going into the future. So I want to thank you for taking time today. Alicia Eng and Dr. Claire Trascott, thanks for talking with us.
You're welcome.
Thank you.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.